Section 1. Introduction. 2 patients, 2 problems, 1 crucial distinction. Alright, let's set the scene. Imagine you're a nurse on a busy medical floor. In room 301, a 62-year-old woman is a few days post-hip surgery. Suddenly she's gasping for air. Her heart is racing like she ran a marathon. She has sharp chest pain that worsens with a deep breath. Your mind jumps to pulmonary embolism, a PE. It's a medical emergency. Every second counts. Now walk down the hall to room 305. A 75-year-old man with a history of heart failure. He can't lie flat without feeling like he's drowning. Muffled breath sounds at the base. Chest X-ray shows fluid around his left lung. A pleural effusion. Both struggle to breathe, for totally different reasons. We'll break down what they are, causes, how to spot them, and what to do, so you can be NCLEX ready and real world. In room 301, think PE and act fast. In 305, understand fluid and address it. Let's get into it, and stop confusing PE with pleural effusion. Section 2. What exactly is a pulmonary embolism? A PE is a blockage in a lung artery, usually a blood clot. Think of lung vessels as highways. A clot causes a traffic jam. It often starts as a deep vein thrombosis in the legs. A piece breaks free, an embolus. It travels through the venous system into the right heart, then out into the pulmonary artery. As vessels branch smaller, the clot gets stuck. A PE, blood can't reach alveoli beyond the clot. Oxygen levels can drop. The right heart faces a roadblock and strains against high pressure. It's a dangerous chain reaction. Severity depends on clot size and location. Small clots may be subtle or even asymptomatic. A massive saddle embolus can block most flow. This can cause sudden circulatory collapse and death. Recognize risk rapidly. PE is a life-threatening emergency. Next, the sneaky culprits behind PE. Causes and risk factors for PE. The sneaky culprits: Virchow's triad, stasis, hypercoagulability, endothelial injury, stasis, slow pulled leg blood with immobility. Big post-op risks: hip and knee surgery, bed rest. Long flights or car rides, a classic travel DVT risk. Hypercoagulability: blood is stickier than normal. Risks include cancer, pregnancy, hormones, and factor V Leiden. Vessel injury from surgery, IVs, or inflammation promotes clotting. The body sends alarm signals: sudden shortness of breath with sharp pleuritic chest pain. Tachycardia, tachypnea, and hypoxia are common. Severe cases, cyanosis or syncope. Hemoptysis can occur from pulmonary infarction. Many report a feeling of impending doom. Take it seriously. D-dimer rules out PE in low risk when negative. Positive doesn't confirm PE. Many conditions elevated. CTPA is the gold standard to see the clot. Once we've confirmed a PE, act fast. 2 goals: stabilize now and prevent new clots. Oxygen, large bore IV, cardiac monitoring. Start anticoagulation, often heparin in hospital. IV unfractionated or low molecular weight heparin. Bridge or transition to warfarin or DOACs. If unstable with shock, thinning blood isn't enough. Consider thrombolytics like TPA, high bleeding risk, or embolectomy in severe cases. You're the frontline monitor of respiratory status. Watch for bleeding, urine, stool, bruising, IV sites. Educate on meds, follow-up, and clot prevention. Promote mobility and prevention strategies. Your vigilance can change outcomes. Now, switch gears. Pleural effusion. Let's talk about pleural effusion. Fluid in the wrong place. Excess fluid collects in the pleural space. 2 pleural layers, visceral and parietal. Normally just 10-20 ml to lubricate movement. When fluid accumulates, it compresses the lung. The lung can't fully expand, causing dyspnea. 2 main types: transudate and exudate. Transudate is watery from pressure imbalance, most often heart failure. Also liver or kidney disease with low proteins. Exudate is protein-rich from local inflammation. Causes include pneumonia, cancer, viral and autoimmune diseases. If infected, pus-filled empyema needs urgent care. A PE can also cause a small exudative effusion. Symptoms are usually gradual, progressive dyspnea. Worse when supine, often a dry cough and chest heaviness. Next, causes, diagnostic keys, and how we manage effusions. Draining fluid helps, but it returns unless you treat the cause. Most common on the floor, CHF causing transudative effusion. Pneumonia often triggers inflammatory exudates. Malignancy is another major cause. Expect decreased or absent breath sounds over fluid, dullness and decreased fremitus. Fluid dampens vibration. X-ray shows blunted costophrenic angles. Ultrasound at the bedside maps fluid and guides procedures. Thoracentesis relieves symptoms and sends fluid for analysis. Use Light's criteria to classify transudate versus exudate. Check cytology and cultures when indicated. Treat the underlying cause, diuretics, antibiotics, etc. Large or recurrent effusions may need thoracentesis or chest tube. For malignant recurrence, consider pleurodesis. Monitor respiratory status and manage drainage systems. Watch for pneumothorax, provide analgesia and deep breathing teaching, ready for a side-by-side that sticks for NCLEX and the floor. Let's put them side by side. Your quick cheat sheet. PE, clot in pulmonary artery. Effusion, fluid compressing from outside. PE, onset is sudden, effusion is gradual. PE, pain is sharp and pleuritic, effusion is dull or heavy. PE drives tachycardia, tachypnea, hypoxia. Effusion often normal unless large. PE lungs can be clear. Effusion has decreased sounds and dullness. PE, CTPA or VQ. Effusion, X-ray, ultrasound and thoracentesis. PE needs anticoagulation. Effusion needs cause-based therapy and possibly drainage. Overlap exists. A PE can cause an effusion and big effusions stress vitals. Any respiratory distress, sit up, check SpO2, give oxygen, seek your IV. Sudden dyspnea, sharp pain, fast heart, think PE, anticipate CTPA and anticoagulation, watch bleeding risks. Gradual dyspnea with basilar muffling, think effusion, prepare for X-ray, ultrasound and possible thoracentesis. Teach prevention and adherence tailored to PE or effusion. Keep the red flags top of mind for both conditions. Master the differences, communicate clearly and act fast. Stay safe out there.